dysfunction itself, and it's because they come with structural problems many times. So when we're looking at kids, yes, we have these dysfunction. You started cardiovascular and med-surg.
Not yet.
Okay. Failure to pump, that's one of the things. So that'll be with the congestive heart failure and what's going on. Obstruction to flow. Adults really don't have that kind of a problem. Kids, oh yeah. Better. Regurgitation, adults have that. Shunted flow. We're going to spend a lot of time on that because that's where you see the children in the hospital. And due to that, everything else starts falling apart. Disorders of cardiac conduction, not going to talk about that. You'll hear it in med-surg. Kids don't have the same problems as adults. They do have a few dysrhythmias that are rather fascinating, but it's a little different. And rupture of the heart or major vessel. No, we're not touching that one. So there are those dysfunctions that do occur, and as I say, not all of the things that are wrong happen because of pediatrics. So let's look at the heart from the very beginning and what is going to be creating the problems with children. When it comes to the cardiogenesis, the development of a heart from a simple tube, starts out a simple tube that begins about 3 weeks into gestation itself. And that's where a lot of cardiovascular development is starting. It's not from it starts 2 weeks in and then occurs anywhere along 4 weeks to 7 weeks time period as far as the gestation and development. So we have the cardiac septum that'll start at the heart. The straight tube will start to divide into 4, and the septum starts some of its development. It is not a complete development, it's sort of mildly, and that's where we see a lot of problems that will occur in children because it stops developing along the way. So, the main cause for most of the cardiac problems is the sporadic hit and miss in development itself. So when you look at it, you think, it looks like a real heart. Well, that's where about it ends after that. Going on. So, So, when looking at circulation and what is going on, we're looking at what's going to happen with the child and what's going on. It's going to be a change in fetal circulation to circulation we see in adults. All right, this one. Fetal circulation. What is going on? How does the baby get oxygen? Because it's certainly not doing any breathing. So in the development is what is occurring. So you'll get this again ad nauseum and OB, but I need to give you a touch of it so you have an understanding where the problems are. So the oxygenated blood needs to go to the baby. So we have the placenta. So remember, in the adult, blood leaving the heart leaves by way of the artery. Right? So you have oxygenated blood leaving mom, going to the placenta. Remember that blood enters the heart through veins. So what you have from the placenta delivering blood to the heart is actually veins, umbilical veins. So it was an artery that brought oxygenated blood to the placenta. Placenta now is moving the blood to the fetus, but because it's moving blood to the fetus, it's veins. But it's veins that is carrying oxygenated blood. So we have the umbilical veins that are now taking this, going all through the liver and all this portal circulation, day and good time going on, up to the heart itself. So that's the beginning of what's going to be happening. The oxygenated blood enters the heart due to umbilical vein. That vein is going to connect with the superior and inferior vena cava, et cetera, and bringing blood in. So all that sounds wonderful. Except now we are worried to see the development of a So what is occurring is we have oxygenated blood coming up, and in this case, the inferior vena cava itself, into the heart. Now, there's also going to be unoxygenated blood via the superior inferior vena cava, because that's blood that is already circulated through the baby itself, and it's coming back to the heart for the exchanges to take place. So oxygenated blood coming up into the right atrium, just like you would expect it to, as a normal adult heart and all, down to the right ventricle, but it's mostly oxygenated blood. Does this blood need to go to the lungs? No. Very little of it is going to go to the lungs, so the lungs aren't doing anything anyway. So during the fetal period, we have this oxygenated blood leaving the right ventricle. Some of it is going to go to the lungs, because the lungs need its blood supply also needs to have the nutrients of oxygenation. But since it's not being oxygenated in the lungs, essentially most of that blood is going to leave the heart and go into systemic circulation through the aorta. So there's a shortcut. If it's not going to the lungs and then back to the left side and everything else, how it's going to get to systemic circulation? By way of this cute little connection called patent ductus arteriosus. So this is a fetal structure that will take oxygenated blood basically from the right side of the heart, because that's the only thing that's entering that, blood cell circulation, etc., to the aorta, which will then be distributed to the rest of the baby's body. Make sense? Yes. Little part. Okay. I want you to keep that. Keep this in mind. So the patent ductus arteriosus is only useful during fetal life. Now, also, since there's really no oxygenated blood going to the lungs and having to worry about being oxygenated there, we might as well just, everybody says, send oxygenated blood over to the left side of the heart. It's not going to the lungs, so how is it going to get over to the left side of the heart? Well, there's this little septal defect. Remember, previously we had the development of the septum, but I told you it wasn't complete, so there's still an opening between the right side and the left side of the heart, and it is fondly called the foramen ovale. So oxygenated blood will also go from right side to left side through this hole in the atrial septum. Still with me? All right. So two things, patent ductus and the foramen ovale, which is in the region somewhere. That's wonderful. That's fine. It only works well during the fetal life. At the time of birth, there is going to be a massive change in the hemodynamics of what is occurring. As soon as that baby takes a breath, and that's what triggers or takes a breath, and all these changes that take place within the chest itself, and that foramen ovale, the opening between the left and right atrium, starts to shut. Because we don't want a leakage, because now the oxygenated blood is sitting on the left side. There's nothing coming in on the right side but unoxygenated. So the foramen ovale will close. The patent ductus will also close in about totally within a week or less, like the left part. Well, and then we have what we call postnatal circulation taking place. So all of the blue stuff unoxygenated is now on the right side, and all the oxygenated stuff is on the left side. So the patent ductus closes, oxygen saturation changes, and everything starts to look like what you'll be hearing about in the adult. So pressure is higher in the right side prenatal, postnatal, it changes. So what happens if those don't close? Those are the children children who see PMI, those are the children that are going to need intervention. Those are the children that turn blue a lot. Those are the children that are going to have blood problems. The lungs get really fussy about the pressure within the chest and which direction blood is flowing. So you have cardiac problems and there can be lung problems because the vasculature in the lung is very low pressure. It does not handle high pressure. And when high pressures occur, it is destruction of the lung structure itself, the vascula. Make sense so far about what kind of problems you're going to see in these children going on. So, what is it? The absence of so the deficit, yeah, 47 days or more. So, entering and what's happening. So, when we're looking and doing these assessments of children coming in, certainly there is that initial assessment after the baby is born and get in the warmer and everything's going on and makes it to the nursery. And the nurse and the pediatrician both have a stethoscope in and we're listening. We're going to hear some sound, some abnormal, adventitious sounds because the patent duct has closed totally and the brachial may still have a little bit of a leak there. But otherwise it sounds pretty good. It's when it doesn't sound pretty good the next day, and the next day, and the next day, that we know this child is going to be needed. Watch carefully. So, inspection. How does this child look? What is going on with the child? Now, the infant's cardiopulmonary circulation is proportionally larger, much larger body surface than an adult. So we're rather fond of our heart and lung as an adult. And it's size for us. But in children, it's, for all practical purposes, it's oversized for your body surface. So there's a whole lot going on and a whole lot that can go wrong and then affect the rest of the body itself. Also, the placement of the heart. You know already that the heart kind of rolls to the left. It's on the left. Well, majority of it's to the left. That's not the way it is in a child, in an infant baby. It's sitting up front. It's more of a transverse angle. So it's more frontal. It hasn't made that roll. And why does the heart in the adult roll to the left? I remember telling you this in the first class. Why does it roll to the left? What? You know that big left ventricle? Much bigger than the rest. Things tend to follow weight. It rolls over. So the child doesn't have all of that quite yet. So it's much more frontal. So when you're listening to the heart, when you go to listen, I'm going to say for the PMI, or listening, and you're going to find the PMI. Where do you find it on an adult?
It's intercostal.
Right, this intercostal space is clavicular and there's no pathology there. On a child, you're going to go for the fourth intercostal space. So it's a bit higher because of the way it's sitting in the chest itself. It'll roll as time goes on. By a month, a newborn's ventricles are about equal itself. And if you're feeling for the apical pulse, listen for the apical pulse, it's going to stay there about at the fourth intercostal space until they're in grade school, until they're 6, 7 years old. So don't be down here on these children. Infants definitely, but even if toddlerhood and up to the beginning of grade school, they're still at the fourth intercostal space. You're not listening at the fifth. You're going for the apical itself. So we're looking to find out what is going on, and I give you the page numbers, inspection, propulsion, all that wonderfulness. And children get the same diagnostic evaluation as an adult. UKGs and echoes and finding out what's there, what's not there, etc. We're going to talk a bit about cardiac cath, catheterization, what is the pre and post care of a child with those. We're looking at dysfunction. Okay, so what do we see in kids when there is dysfunction? It's based on a cardiac anomaly itself. What's going on? ECG, not so much. There's only a few anomalies. Changes in EKGs that are specific to kids. Right? Like Parkinson's syndrome itself. But the one thing we will see is tachypnea and tachycardia. Now, they already got a fast heart rate, they breathe down and all, but it's supposed to slow down as they get older. Therefore, individual kids with cardiac dysfunction, it doesn't. It's supposed to be maybe rather higher than anticipated. If it's an easy one to pick up on, when in doubt, look at if they're eating. So this is a child that is difficult to feed. Something's wrong. Poor feeding, refusing a bottle or taking a couple of sucks of the bottle and then becoming exhausted. Those are some serious problems that we worry about with them. Failure to thrive, the poor weight, they don't gain activity, they're not playful at all, regardless of the age. So we're looking at, are they growing? What's going on with the children themselves? Developmental delays, they're not growing. When you look at their percentile, they're not meeting standards at all. And then we go back, and there's always, when you're looking at a chart and you're in the nursery or a child that's coming in, very young child coming in, what was that prenatal history? If we pick up on some problems that we know will exist. And what things worry is, once again, seeing what measles will do to infants. We know what measles will do. Mom coming down with the measles in that first trimester, devastating to the fetus, absolutely devastating. So we're anticipating starting to see this coming back again because of the lack of vaccination. So looking at prenatal history, you'll see with these children, there is definitely that on their chart. And then any family history of cardiac disease itself. Not talking about having atherosclerotic disease, although that may come up later on, but what kind of problems may have been present for these children going on. With the history, family history, also there's interest in whether or not there has been a history of miscarriages. Has mom lost babies before? Because that speaks to some other things that are going on, and why was that child lost? It may be due to the fact that there was already some severe cardiac mutation and the body basically rejects the child for a number of things. Sudden infant death, is there a history of that within the family? Because that's kind of a clue. Some other things that need to be watched very carefully in the child itself. Then naturally, any history of a cardiac heart defect in family history, close family history. Okay, so we said the heart, instructions wrong, etc. Well, what we're looking at then, as the child is going on, we're looking for clutters, which is seen with cardiopulmonary problems. That low oxygen point itself can be due to cardiac or can be due to pulmonary. So it's always called a cardiopulmonary problem itself. And we can start seeing on young children the clubbing of fingers, particularly those that have the type of structural defect that requires multiple surgeries to correct. So easy thing, it tells you about how is this child doing. It's not them turning blue on you, so there's enough of that going around. But that they will show the clubbing even at a very very young age. You'll see it on toddlers. Cardiac mashing. When looking, just keep this in mind and write down your answers. I'll be getting it along the way and then see how close you are to the answer. The only one that's never been discussed is Mongolian spot. That's too hard to pick out. All right. Let's listen to some hard sounds. Now remember, it said that the heart is positioned differently. More angle, trapezoid than horizontal in the chest itself. So when you're listening to hard sounds, they're going to be louder. Don't have to spend a lot of time. Louder, higher pitch, shorter duration. So they can move quickly. Remember, the children also have a faster heartbeat, so we're going to have to listen quickly for what's going on. One of the things that they often pick up is S3. In an adult, an S3 is not likable. In children, we find it about a third of all kids, and it doesn't mean anything. It's just there, and it will go away with time. So just be aware that, remember I had talked about S1 and S2, and on S2, the physiologic splitting of S2. Do not mistake that for an S3. So, ideally when listening, the sequencing, when you're going, listening to a child's heart, is starting at the aortic area. You're over here at the second intercostal space itself, the second rib near there. So you start at the aorta and work your way around to the pulmonic. Earth point, you just listen, it's supposed to be equal there, and down through the mitral and tricuspid. So just listening for what direction you're going, where things are located, not looking down as far on the child's chest as before. And remember that the anatomical location of the valve is not where you actually have your stethoscope over. You have it over where they're bent. The sound from those valves are heard. So don't say this is where the valve is. It is not. Touch further away, but that's just the best spot in which to listen. And when listening to a child's heart, you should always place the child in two positions. You can listen to them lying down and then set them up or roll them over, but it always should be in two positions for a child. You usually do that with adults also, but you particularly want to do it with children. Okay? All right. So you're busy listening for sounds. And the turbulence, murmurs. A child with a cardiac defect is going to have murmurs. It's going to be really noisy because there's so many spots for it. You can have just a patent ductus that shouldn't still be patent. You can have the ovale foramen, which shouldn't be foramen ovale, which shouldn't close, and then anything else that I'll be talking about. So listen for murmurs, and they grade them. One of the things, and I'm not going to use it, what does this mean is that, but be aware when you're looking at the chart, how they're graded 1 through 6. There are the innocent ones, those that we expect to hear, such as still will hear some of the patent ductus, maybe a little bit of blood going through foramen ovale. On the neonates, everything should be closed before they have another month. So they're innocent ones going on. And then there are some that are functional, but there is a problem. And then the organics. And we spend more time hearing the organics itself. So if you hear